Hello, this is Chapter 9 on joints, and this is going to end our Unit 2, osseous tissue and bones. So without joints, the body would have basically couldn't move because we would be stiff, linear bones. And so what joints allow us to do is bend so that we can move around, run, walk, and as you can see here, make angles with our appendages. So joints can also be called articulations. They're the connections between bones. And the joints themselves may or may not move. So for example, we do have some joints like fibrous joints in our skull that basically don't move around after our skull becomes completely ossified. Some joints have cartilage or dense connective tissue. Some have components that have fluid within them, but you're always going to have some connective tissue element to a joint. So joints are based on joints are named, I guess I should say, based on a couple different things. You can name a joint based on its functional movement, or you can name a joint based on the type of cavity it has. So why do they do this? Well, it kind of depends on the field of medicine or of science you're working in. Functional classification tends to be things kind of like, you would still name joints based on their functionality as a doctor, a general doctor, but in physical therapy, if you're a PE or a PT, then you would probably classify joints based on how they move. So we have the immovable joints, the synarthritic joints, the slightly movable joints, amphiarthritic or amphiarthrosis joints. These are typically a part of the axial skeleton. And remember, what is axial, right? Axial, is it the axis or the appendicular skeleton? Amphiarthritic joints are going to be things that you see in the core of the body. Freely movable diarthritic joints are the most common and probably the most familiar that we think about because they're associated with the appendicular skeleton. They're associated with our arms and our legs. So diarthritic joints are going to be joints that are going to be like in your knees and in your elbows. Now, if we base our naming on joint cavity type, we have fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints typically are the synarthritic joints, okay? Those ones that are basically, they don't move. They might be slightly compressible. So those would be joints in your skull where the sutures are. Cartilaginous joints would be the amphiarthritic joints, things that you would find between, let's say, for example, vertebra in the spinal column. These would be the pieces of articular cartilage between individual vertebrae. And then you have the synovial joints that are also called the diarthritic joints. And these are going to be, your knee is probably the greatest example of a diarthritic joint, but also your elbows, maybe not as much, but definitely your shoulders. So we'll be getting to how each one of these joints is structured, why they're important, and how movement is influenced based on the structure. Now, one of the things I want to bring up right now, for those of you who are listening to the lecture, you've probably noticed that I do a whole lot of structure and function. This is what it looks like, and the components allow this item to do this. You're going to be hearing a lot about that over and over again in this course, and you're probably going to have to identify structure and function on exams. So whenever I bring up, here's the structure, this is how it works, basically. Pay attention to that, okay? So let's start with our fibrous joints. Fibrous joints do not have a cavity. It's basically a bunch of fibrous connective tissue connecting bones, holding them together. So sutures of the skull, you see these little bony edges, we'll see a picture in a minute, of the skull plates of the different bones of the skull. Remember what those are, the parietal, occipital, so forth. And those little bony edges allow the two bones to interlock with one another. The dense fibrous connective tissue hold those bones together. They are slightly, I guess you could say they can absorb some compression, but they don't bend like an elbow or a knee. Gamphiosis is the region between the individual teeth and alveolar fossa, say for example in the mandible and the maxilla. The gamphiosis is a type of a fibrous joint where you have a ligament holding each individual tooth in place. So the gamphosis between the tooth and the hole, basically, where the tooth sits in it, that is the joint, okay? And if you kind of tug around on some of your teeth, you'll see that they wiggle a little bit, and that's a good thing. That helps to absorb shock when we chew food or when we're biting stuff. It absorbs shock, allows the tooth to move around, especially, you know, when you're chewing something kind of hard, like a big piece of meat. The teeth can wiggle around. They can still perform their function of cutting and grinding, but the tooth itself doesn't take a whole lot of, I mean, it does take pressure, but it helps take some of the pressure off the tooth so the tooth doesn't crack, okay? And then this syndesmosis is an example where ligaments hold bones together, okay? An example of this would be the tibia and the fibula. That's the that region that we were looking at in the last chapter where you saw tissue holding the tibia and the fibula together, but they don't really do much. It's just a series of ligaments holding the bones together so that you can have a little bit of compression and kind of twisting movement and structure, but it's not a true joint in the way we think about a joint as in like a knee or an elbow or shoulder. So here's an example of the sutures here. So the sutures is a type of a fibrous joint, and you can see the coronal, the squamous, the lambdoid suture. Each one of these you should know for exam number 2. And the sutures are joints that are the joinings or where you have two bones coming together and they're held together with fibrous connective tissue. They're essentially immovable, although they can take a little bit of pressure and allow some, you know, not bending, but the skull can move a little bit based on the structure of this joint. Here's an example here of the suture line. Dense fibrous connective tissue holding this line together. Here's the dense fibrous connective tissue over here, the syndesmosis, holding together the ulna and the radius. Same thing as the tibia and the fibula, okay? And then over here, here's the periodontal ligament, all right, associated with a tooth. So here's the enamel of the tooth. Right here's the tooth socket, all right, this region. And then the gamphiosis right here, or gomphiosis, I always say gamph, I don't know, it's gomphiosis, is the joint between the tooth, the periodontal ligament, and the socket of the tooth. So this is the root. The whole thing here is the tooth root. Now, interestingly, we talked about the development briefly of the newborn skull, and newborns have very, very thick regions of fibrous connective tissue. These joints are definitely much more movable than the joints, the sutures in the skull of an adult. Now, you know, again, you get maybe a little bit of compression. Here, these sutures are designed to allow the offspring to escape the mother's birth canal, which means that these regions, the frontal bone and the parietal bone and the occipital bone, for example, can all kind of move around a little bit based on the fact that these fontanelles here are flexible. This changes as we grow, and the soft spots, or the anterior fontanelle, sphenoidal fontanelle, and so forth, these fill in with bone and connective tissue, that fibrous connective tissue as we age and grow. Okay, so those are the immovable joints. Let's move on to the cartilaginous joints. Cartilaginous joints also have no joint cavity, so that's the kind of thing to look for the next exam. What classifications of joints have a joint cavity, which ones don't? Basically, cartilaginous joints are regions of cartilage between bones, all right? And so we have hyaline cartilage, okay? The synchondroses, chondro always means cartilage, okay? Synchondrosis. And then we have the symphysis. Again, Valerie, unable to pronounce things. Symphysis, which is fibrocartilage. What's the big deal? The hyaline cartilage is going to be used more to absorb shock. The epiphyseal plate, for example, in the metaphyses of bones, the epiphyseal plate has a considerable amount of hyaline cartilage because as we're growing as a child, the cartilage allows for some compression of the bone as you're running around and jumping and all that stuff. But that's also a region that can become ossified through the activation of osteocytes, right? So the epiphyseal plate is the growth plate that is within growing bones, okay? And that is associated, that is a part of that hyaline cartilage line in synchondrosis cartilaginous joint. In fibrocartilage, for example, of the pubic symphysis and then intervertebral discs, these regions here are places where there's a lot of compression. And so those regions, that fibrocartilage is just basically like a shock absorber, okay? And so that's going to take up shock as we move around throughout the day, helps fight the forces of gravity between vertebra on the vertebral column, and basically cushion blows to individual bones. So here's an example of an intervertebral disc between the bodies, the vertebral bodies of two individual vertebrae. Over here, we're looking at the epiphyseal plate, temporary hyaline cartilage in this particular bone here. Maybe it's the, I don't know, maybe it's the humerus, the base of the humerus. Over here, this line is going to become ossified eventually as we get older and we're done growing. And then over here is the pubic symphysis. The pubic symphysis is the joining between the two individual pubic bones, okay? Remember, what's the difference between a pubic bone and the pubis, okay, or the entire pelvic girdle? This is the whole pelvic girdle when you have the sacrum, the two pubic bones, and then the pubic symphysis. Okay, so these are, coming back here, the cartilaginous joints. So I'm going to go back. Sorry, I'm not trying to give you guys a headache here. We have our fibrous joints that we talked about, the cartilaginous joints. We're now going to move on to the synovial joints, which is what most people think about as joints. Synovial joints are complex. They are typically found at the ends of long bones. They are what we call diarthrotic. That means that they have di for two. Arthrotic means that they're it's kind of like bendable, I guess you would say. And it gives us a very wide range of motion. Now, synovial joints have 6 basic characteristics. Since there are only 6, this seems to me like this would be a really good question for the exam. We have articular cartilage within a synovial joint, the actual joint capsule itself, the synovial membrane that lines the joint capsule, which produces synovial fluid. Okay, so the joint cavity or the joint capsule has synovial fluid within it, produced by the synovial membrane. And then we're going to have lots of accessory structures. And those accessory structures depend upon which joint you're talking about, which synovial joint you're talking about. So some synovial joints are going to have a tremendous number of, a tremendous number of ligaments. Other synovial joints will have things like bursa. So we'll talk about that in a few minutes. There are also plenty of sensory nerve endings and some blood vessels. Blood vessels supply the synovial joint with blood, obviously, but blood consists of the liquid component, which is plasma, and then the solid or formed components, which are red and white blood cells and platelets, okay? The plasma is what can be converted into synovial fluid. So one of the most fascinating things to me about the human body is that we drink water, right? Water is absorbed into our bloodstream where it becomes plasma, and then plasma can become all kinds of stuff. Plasma is delivered to tissues. It can become interstitial fluid. It eventually can become intracellular fluid inside of cells after they've absorbed water through, or plasma in this case, through penocytosis. They can become synovial fluid. I mean, water can become everything in our body. It is our hydration, right? So whenever you're drinking water, this is how our joints maintain their pressure and the appropriate function and production and lubrication of synovial fluid. Is if you drink water, eventually some of that will become that synovial fluid. You'll hear a lot more about that in physiology, but again, structure, function. Synovial membranes produce synovial fluids. Here we go. Synovial fluid function. Lubricates, reduces friction at joint surfaces. That's a big deal, especially if you're walking a lot, if you're out hiking, or if you're running, or if you're biking, all that movement causes a tremendous amount of friction. It also nourishes the chondrocytes. It gives them oxygen, or brings oxygen to the chondrocyte. It enters through the articular cartilage. Basically, as the joint is moving, fluid can escape from blood vessels associated with the cartilage, associated with the bones. And so the chondrocytes are nourished with synovial fluid, because the fluid gets basically enters the joint at that point. As the articular cartilage absorbs shock, synovial fluid can get squeezed out of the joint. So in that particular case, this articular cartilage would be things like the intervertebral cartilage, right? The discs. If you have adequate synovial fluid, the discs themselves have that fluid as a basically as like a another level of compression protection. And then when synovial fluid is under pressure, the fluid is acting normally. When the pressure is released, fresh fluid soaks into the cartilage, and the cartilage is nourished and so forth. And so basically the synovial fluid, in addition to lubrication, reducing friction, nourishing chondrocytes, it acts as a shock absorber. And so this is a great example of having kind of that cartilaginous squishy pad functioning as a shock absorber, and then fluid around it also acting as a shock absorber in our system. So here is a real simple sketch of a synovial joint. The articular cartilage is going to be on both faces of the bones. Don't worry about the names of these bones right now, it doesn't matter. We have the marrow cavity, we have the spongy bone here, more spongy bone here, periosteum on the outside. The periosteum is the connective tissue surrounding the bone. We have a fibrous joint capsule, and then here's the synovial membrane here in pink, the synovial membrane producing synovial fluid that's going to nourish this articular cartilage, all right? Later on in this lecture, we're going to talk very briefly about osteoarthritis and how osteoarthritis breaks up articular cartilage inside of a synovial joint. And so basically, again, articular cartilage is a smooth bone covering that protects each individual bone, keeps the bone from grinding on its partner, decreases friction. It is similar to hyaline cartilage, except there's no perichondrium, so there's no connective tissue on the outside, and there's more water in the ground substance. It's squishier, basically. Now, looking at, all right, so this is just a general view. We are now going to look at a side view, a lateral view, a sagittal section through the knee, okay? And so this is a much more complex picture. So here's the femur, here's the tibia. We still have our articular cartilage on the end of the femur, on the end of the tibia. There is right here an intracapsular ligament. Don't worry about the name of it right now. It's one of the ligaments that hold the femur to the tibia. We have the quadriceps tendon, so here's part of the quadriceps group. We have on the outside here, here's the joint capsule, more joint capsule out here, okay? Here's the patella, a little bit of articular cartilage on the back of the patella. There is a fat pad underlying the patella, helping protect the patella from grinding against the femur and the tibia, all right, in addition to that cartilage. We have the patellar ligament holding the ligament in place from on the more inferior side here, okay, it's distal. That patellar ligament connects to the tibia here, and then you have the quadriceps tendon also connecting to the patella. So the patella is this bone that's kind of hanging out in space, being held in place between the quadriceps and the patellar ligament. Here we have the meniscus. The meniscus is an interesting piece of tissue. You have two of them, one on each side. When you have a meniscus tear, that tissue becomes loose and kind of floats around in here and can cause problems. And then here's the synovial membrane, again in pink, but it's hard to make out. It's right here. There is synovial membrane. You can't see it over here so well. It's right here. Synovial membrane here and synovial membrane here, producing synovial fluid. So the fibrous connective tissue, the synovial membrane, the fibrous connective tissue connects to the synovial membrane. Sorry about that. The synovial membrane is deep to that connective tissue in the joint capsule. So the joint capsule is that fibrous connective tissue, and then underneath it's the synovial membrane. They surround the joint, doing their jobs. It encloses the entire joint cavity, helps hold the bones together, and then you have the alveolar connective tissue, and it produces the synovial fluid. You can't necessarily see that over here. Don't worry about it right now. It's just, you know that the synovial membrane makes that synovial fluid. This is a figure from your book. So this is showing that base of synovial joint. This would probably be more of an anterior view of the femur and the tibia. It's a simplified view. So accessory structures, what else are you going to find in these synovial joints? So we looked at the cartilage and the fat pads. You typically find these in really complex joints. There are some simpler joints in your fingers and in your toes, but these are going to be more in your knees, your shoulders, and your elbows. They help the cartilage and the fat pads help the joint change shape and helps maintain pressure inside of the synovial capsule. The articular discs, or the meniscus, are fibrocartilage pads. They, again, are part of the shape of the joint cavity. Sometimes when the articular disc separates from other structures, it's going to restrict movement and cause problems with synovial fluid production and flow. So that would be an injury within the articular disc. The fat pads help protect the articular cartilage, like we saw in that more complicated lateral view of the knee. Fat pads also help just kind of fill in space. So this is a place where on our body, fat is really used to cushion a joint. And you'll typically find them around the periphery of a joint. So if we come back here, here's a fat pad. Here, technically, this underlying fat is a fat pad. So these little pads, or here's a little fat pad there, are helping maintain pressure of the synovial joint, but also just kind of taking up some stress and strain as we go through our day and walk. Other accessory structures are going to include ligaments. These are obviously, as we've always talked about, really dense connective tissue that helps stabilize the bones of a joint. We have the intrinsic ligaments. These can also be called capsular ligaments, and they are in areas where you have a thickening of the joint capsule. Then you have extrinsic ligaments. These separate the joint from the capsule and are typically on the inside or the outside of the joint cavity itself. So we have the extracapsular ligaments on the outside of the joints and the intracapsular ligaments, which are inside. Let me see if I have a picture. Let's come back here. So this intracapsular ligament would be like part of the ACL and so forth. And then we're going to have extracapsular ligaments, right here. Okay, you don't need to worry about names in these pictures right now, but you do need to know the difference between intra and extracapsular ligaments. And it's pretty obvious. It's, ligaments that are on the outside of the capsule or ligaments that are on the inside. Now, bursa, these are kind of weird because these are pockets of connective tissue that become filled with synovial fluid, and they're like little gel-filled pillows inside of the joint. Typically, you're going to find these where ligaments and tendons rub against each other and against other tissues, and so this is another way of reducing friction inside of a joint. It can become connected to the joint cavity, or it can be separate. And it's also used for shock absorption. So if we come back here to this picture again, you'll see in green individual bursa, okay? And these little bursa are important, again, for absorbing in the knee here, absorbing shock from the anterior side of the body. So there's a bursa right kind of underneath, well, not underneath, but kind of, you can't feel it when you touch your patella, but it's associated with the patella. It's really skinny. We have the synovial tendon sheaths. These are, kind of long, thin shaped bursa, and they tend to go across the bony surfaces of a bone, and it allows the tendon not to produce a lot of friction over the bone. The adventitis bursa, the bursa in abnormal locations. kind of weird. When we say abnormal, it's just kind of like you would never guess that a bursa would be there, like associated with the patella. And what happens to the bursa when they get upset and inflamed? We get bursitis. It's very painful to get bursitis, but the only thing that really helps with bursitis is to stop activity, because bursitis tends to get worse as you work more and more, work the joint more and more. So basically, this is where all of you athletes out there, including me, when we get bursitis, we have to slow down, ice our joint, elevate it, help it out a little bit. Bursitis can go away, and sometimes it takes a long time to go away, because once the inflammation is introduced, it takes a while for inflammation to kind of go away. So here's a picture from your book showing you, in addition to like the fat pad, the prepatellar bursa, the anterior bursa, and so forth. You can see here the anterior cruciate ligament, the ACL, and there are other ligaments inside of the knee, but we won't deal with that right now. So what is the deal with joints? Going back to their function, a joint, one of the problems with joints, even though it gives you mobility, a joint is not very strong. So those joints that are strong, the synarthrotic joints in your skull, the sutures, super, super strong, but virtually no mobility. When a joint gets mobility, that is where weakness is introduced. And basically, a joint becomes damaged when the joint exceeds its range of motion. And so, for example, one of my injuries, because I can't get mad at myself, I got kicked on the lateral side of my left knee in college. I do taekwondo, and somebody tried to sweep me, and they swept too high and kicked the side of my knee. And ever since then, after that initial knee injury, every so often I end up with pain in the joint, and it's just an old injury that's not going to go away. It's not so bad that I need surgery, but it's not great either, to be honest. When I run a lot, I notice it. So damage that was introduced to my knee from a lateral blow eventually will result in more collagen fibers being inserted into the joint capsule itself, which then leads to changes in the shape of articular cartilage. That can limit movement. Luckily, I don't have any limitation on movement. However, I do have extra tension in some of the tendons associated with the joint, which means I end up with tendonitis in my left lateral side of my knee often enough. So that's just one of those just little trade-offs we have in the structure of our body. You change the structure a little bit, you introduce mobility, and then all of a sudden the structure, while strong, is not as strong as a static or an immovable joint. So let's look at the movement. What types of movement do joints allow us to produce? So there's gliding movement. So in the synovial joints, the joints that allow us to, bend, there are two opposing bones, like the femur and the tibia, that slide past each other. Another example are the carpals and the tarsals, the clavicle and the sternum. And basically, if you represent movement as this pencil, the gliding motion allows the pencil to go forward and back, or right and left. But basically, the idea is that the pencil remains vertical, but the tip is what moves. And so in this particular gliding motion, the bone doesn't move. It is the joint up where the eraser would be that allows this to move. Okay, but it's not the joint itself or it's not the bone itself that's moving. It just, the gliding or linear motion is introduced at the point of the joint. Angular motion, we have adduction and abduction. Adduction is movement away from what we call the longitudinal axis. Adduction is the movement toward the longitudinal axis. So let me come over here. Here's angular motion. Okay, so the tips. So one is going down is going to be adduction. Abduction is coming up. I'm trying to find, I have another figure that I'll show you in a minute. Okay, flexion, extension, and hyperextension. You try not to do hyperextension, okay, because that takes you beyond what anatomical position is, and that's when a joint can become damaged. Flexion is decreasing the angle. So that would be like if you're standing straight, picking up your arm or raising your hand to scratch your shoulder. That is flexion. Extension is increasing the angle of your elbow in that particular case. So flexion is decreasing the angle of the elbow where you use your hand to scratch your shoulder. Extension is increasing it where you're allowing your hands to hang at the side of your body. Circumduction is where you move your arm around in space. And so basically one end is static and the other side can kind of track around in a complete circle. Let me come here. This is circumduction. Circumduction is where like your shoulder is staying in place in your arm. You can move your arm in circles. Rotation is where you're just rotating along the long axis. So here's rotation. One end is stationary. The other rotates around that longitudinal axis. Right and left rotation around the head of a bone, around the head of the femur, let's say. Limb rotation can be medial or lateral. And then forearm rotation is what we call pronation, where the forearm rotates to the prone position or with the palm down facing backwards. And supination is where the palm is facing up. And you're actually in anatomical position here. The palm of the hand is facing anteriorly. Pronation is where the palm of the hand is facing posteriorly. And then here are the movements of the synovial joints again. Sorry, I should have put this earlier on. Now, there are special movements of certain joints, okay? There's eversion and inversion. It's like adduction and abduction of the foot, okay? A complete movement of many gliding joints in the tarsals of the foot at the same time. So in the foot, we don't call it necessarily abduction and adduction. We call it eversion and inversion. So you're picking your foot up or pointing it. Dorsiflexion, eversion and inversion is where the joints are gliding back and forth. Dorsiflexion, plantar flexion is where you're pointing your foot, flexing it, or extending it. So dorsal flexion is where you're flexing your foot up. Plantar flexion is where you'd be standing on your tippy toes, okay? And that is also, in addition to all the gliding joints in the tarsals, that involves movement in the tibia and the talus as well. Okay, now one of the types of special movements that we're able to do as humans is called opposition and reposition, and it has to do with the pollex or the thumb. Many animals do not have a thumb where they can touch the tip of each finger with their thumb. When you touch the tip of your first finger, that is called opposition, okay? And so that's where you have the movement of the thumb that allows it to flex and rotate so that you can touch the tip of each of the other 4 digits. Reposition is where you return the thumb to its original position. So what's important about this is it allows humans to pick things up, use things in unique ways. If you think of a cat or a dog and most other mammals, they're not able to do this. Monkeys can, simians can do this, right? But cats and dogs and most mammals are unable to do opposition or reposition. So this is unique to humans. Other special movements, lateral flexion, bending from one side to the other. This is this is allowed by the vertebral column. It allows you to bend to the right and to the left to, say, pick something up. We have protraction, retraction, elevation, and depression. And so these basically can occur in many, many joints. You can move anterior in the horizontal plane, posterior in the horizontal plane, cranially, where you are standing on your toes. We call that cranial in the vertical axis. So that the vertical axis, let me get my pen out. Vertical axis would be up and down. So that's movement in the vertical axis. So elevation is when you basically stand on your tippy toes. Depression is going back down. And then protraction is moving anterior in the horizontal plane where you're like bending down. So if this is you, you would protract if you bend down. And retraction is moving posteriorly, doing a back bend like that. So here's your head right here. You would bend over this way. That would be protraction. And then let's pretend this is someone's head. And then they're bending back that way. That's retraction. Types of synovial joints. We did talk briefly here about the structure of the knee, but types of synovial joints can be broken down into also the type of articulation you're dealing with. So we talked about the gliding articulation, gliding movement. You can also call a gliding joint a plane joint. You have this in the carpals, tarsals, and the sternoclavicular joints. So remember sternoclavicular joints. Think about that, shoulder. Hinge joints have a convex surface, so that one bone literally fits on kind of the concave end of another. This happens at the elbow and the knee. So one bone sits kind of in a cup, but this is different from a ball and socket joint. We have pivot joints where you have cone-shaped bones articulating with another, they say within a ring of another bone. These pivot joints are, again, they're not like a ball and socket joint. You'll see one of those in a little bit. You don't really have to, it does allow kind of this circumferential movement. We have condylar and ellipsoidal joints. These are oval regions that fit into an elliptical cavity. You'll see this in the mandible, right? The temporal mandibular joint. We'll look at the picture of that in a minute. We have saddle joints. These are kind of interesting because saddle joints, metatarsal one with the trapezium, but we also have a saddle joint. So it looks like the surface with a rider, a saddle-shaped surface with a rider. You're also going to find this on the top of the vertebral column with the atlas and the axis. And then the hip joint is the greatest example of a ball and socket joint. So here is a picture from your book showing you what a pivot joint is. So right here's a pivot joint, right here around your neck. You can like look to the right and the left. Hinge joint, your elbow works like a hinge. The saddle joint in your hands, the trapezium and the carpal bone, allow you to basically bend your hand forward, not so well back. D is the plane joint. A plane joint is basically down in your ankle, allowing movement back and forth so that as you step, there's a little bit of compression that happens in movement so that you don't have a tremendous amount of force being sent back up the leg. The condylar, we used to call it the condylar, but the condyloid joint as well is a joint in the wrist. You'll see when you go back and look at the joint, the bones of the wrist, you'll see how the condyloid joint, they used, again, I was taught condylar, this is condyloid joint, how it allows you to move your joint upwards. You can kind of hold a platter on your hand, and you could bend your hand the other direction as well. So you can, in theory, hold a platter on the back of your hand, but it doesn't work out so well, right? And then you have your ball and socket joint, which the greatest example is the head of the femur with the pelvis. So here is the ball and socket joint, which can also be called a multi-axial joint. So the acetabulum of the hip bone in living hip bone is lined with cartilage, and then here's the head of the femur with articular cartilage here. And so basically, the femur, the head of the femur hits or sits right inside of the acetabulum, and it allows anterior posterior movement, medial lateral movement, and rotational movement. So you can see that here. Here's rotation, medial lateral right here, and then anterior posterior. This is a beautiful example of C1 and C2. Remember the axis and the atlas. And this is one of those saddle joints. Okay, and basically you can see how this ligament is holding C1 and C2 in place. So here's the dens of C2 fitting up into the posterior segment of the fossa here, and the ligament holding it in place. Superior articular facet. Both of these has a little bit of articular cartilage there to help cradle the skull. In the elbow joint, unfortunately, this is not on our figure here. It looks kind of grainy. I would suggest going to look at the figure in your online version of the book. figure 9.17. The elbow joint is a hinge joint. It's held together with a tremendous number of ligaments. So like here, the ulnar collateral ligaments and so forth. It's a complex joint, very much like the knee, although it does have some of its own specific structures and kind of different directions that the ligaments hold the bones onto one another. You can see bursa inside of the membrane. You can see the synovial membrane and so forth. But take a look at this inside in your book, because it's kind of hard for me to describe it here. Here's a fat pad associated with the humerus down here, right there and right there. Hip joint, ball and socket joint. The hip itself has a good number of ligaments holding the femur together with the acetabulum of the pelvic bone. And here's the anterior inferior iliac spine right here. And then the knee joint. Part of the reason I left this, or I wanted to bring this figure in, is because it is a figure from your book. You can always go and look at it in greater detail. But this is a figure that I like a lot because it shows you where we have the meniscus. Here's the lateral meniscus and the medial meniscus. So this is the side of the leg. This is the inside of the leg. Here's anterior and posterior. Here's the posterior cruciate ligament, the anterior cruciate ligament, and then you'll see on the inside, you can't see it here, but you'll see the cartilage here and here. The ACL is inside, but don't worry about that right now. But this is showing you looking down, this is a superior view of the knee joint. Beautiful structure. And then the ankle joint. This is a nice picture because, again, it's showing you a tremendous number of ligaments. The deltoid ligament, which splits into different smaller groups, holding the fibula onto the different bones of the foot. All right. Over here is the anterior talofibular joint. The reason why it's named talofibular joint is because it's moving in the back direction. Here's the calcaneofibular joint, the subtabular joint right down here, and so forth. I am not going to ask you to name all of the ligaments, all right? You don't need to know that, but you do need to look at this picture and look how the foot is held together by a tremendous number of ligaments, basically tough fibrous connective tissue holding the bones together. Here's an example of movements of the body associated with figures in your book. Sometimes this is a little bit easier to follow. This figure, basically, extension, flexion, and so forth, rotational movement, and more movements of the body. Now, I did promise you the temporal mandibular joint. So coming back to the bones of the skull, here's our zygomatic arch, zygomatic bone here, zygomatic process. We have a few regions here. Here is the styloid process that connects to the mandible down here, the base of the mandible. So the styloid process has on it the sphenomandibular ligament. This ligament is super important in helping us open our mouth or to lower our jaw when we open our mouth, okay? We also have here here's the sphenomandibular ligament. This here is the stylomandibular. Did I say spheno? This is the stylomandibular. Sphenoid, this connects up to the sphenoid, sphenomandibular ligament as well. And so these ligaments hold the mandible onto the skull, really tight connective tissue. And sometimes, especially right up in here where you have the articular cartilage, the lateral ligament can sometimes kind of roll over the coronoid process, not the coronoid process, I'm sorry, can roll over it's a condyloid, condyloid process. I'm looking at the wrong bone, my apologies. And when that happens, sometimes you can hear a pop, and that is typically going to cause inflammation inside the joint itself. Here's the condyloid process right here. Here is the articular disc, and if that articular disc gets damaged, somebody can actually end up with osteoarthritis in the mandibular joint. Very, very uncomfortable. So here's another drawing from your book of the temporomandibular joint. The humeroscapular joint, this is where the humerus, the along, the top bone in your arm, associates with the glenoid fossa of the scapula. So this is another ball and socket joint. And so basically what you're going to see is the ridge of the glenoid fossa, a deep, deep socket that articulates with the humerus. And remember that the head of the humerus doesn't have as long a neck as the femur does. So here's an example from your book. Here's the humerus, the head of the humerus right up here. Here is the articular capsule right here in this region. You have the tendon sheath. Don't worry about that so much. Here is the clavicle. Here is the acromion end of the scapula over here, the clavicle. And the clavicle joins with here's a fun one, acromial clavicular ligament, right? So this is the acromion right here. It's part of the scapula. You can't see it wrap around back right now. Here's the glenoid labrum. Here is the glenoid cavity itself in green. Here's the scapula. And then there is articular cartilage associated with the scapula. It's kind of in a weird color. It's hard to see. Here's a different picture. I like this one a little bit more because it's showing you an anterior view of basically your shoulder. Here's the clavicle. Remember, the clavicle is your collarbone. The coraclavicular ligaments join to down here onto the coracoid process. So the coraclavicular ligaments hold the clavicle in place with the coracoid process of the scapula. Here's the scapula right here. Here's the supracoracoid bursa, the subacromial bursa, which is underneath the acromion. It actually gives a nice smooth place for the coracoacromial ligament to slide around as we move. And then here's the supradeltoid bursa. These are the two bursa that develop bursitis. Oftentimes, if you sleep with your arm under your pillow and you sleep on your belly, sometimes you'll end up with bursitis there. Here's the subscapular bursa here. And then lots and lots of tendons holding the humerus onto the scapula. All right, so here's the scapula, the greater wing here. If you look at the lateral view, all right, so you're looking at from on the side of the arm. This is the glenoid cavity right here. This whole region is the glenoid cavity. This is where the humerus head articulates with the scapula. Within the glenoid cavity, we have the tendon, basically the biceps tendon right here, tendon of biceps, the brachii muscle, biceps brachii muscle. Here's the coracoid ligament holding together the acromion to, yep, you got it, the coracoid process down here. And then here's the clavicle. So you're looking at the clavicle kind of head on. And then here's the acromial clavicular ligament right here. And then you have the coracoacromial ligament holding the acromion to the coracoid process, which I think I already mentioned. Here is the subacromial bursa and then the supracoracoid bursa here. Down here, you'll see the actual side of the scapula. Right here, you see the greater wing. This is the side of the greater wing. No, I'm sorry, that's going on to the lesser wing. And then what's happening when we get arthritis? Arthritis is not necessarily always a disease of aging. However, as we age, as we use our joints, sometimes you'll end up with a situation where exposed bone becomes available for the opposite side for its partner to start wearing against. So what's going on there? Sometimes the articular cartilage starts breaking down and you end up with bone on bone grinding. So you end up having worn cartilage. Sometimes those little chunks of cartilage can float around in here and cause more friction. But basically you end up with painful inflammation and joint stiffness because of the damaged cartilage. Osteoarthritis can come around through a variety of reasons. It can be because there was an injury to the synovial joint, okay? It can be because of an autoimmune disease where somehow white blood cells get in there and start recognizing the cartilage and break it down. And it can also just be from joint wear and tear, lots of movement. Very common for runners to end up with osteoarthritis. However, here's the good thing, runners and athletes out there. If we do not damage the cartilage, there are bones, there are chondrocytes in there that will maintain healthy cartilage throughout our life. So there was a study done looking at cartilage in athletes and how cartilage changed over their lifespan. And in some of the athletes, oh, I'm sorry, I'm yawning again. In some of the athletes, the chondrocytes repaired damaged cartilage. So it is possible to repair damaged cartilage. You just need to be able to not damage cartilage that often. So basically, if you're damaging it faster than your body can repair it, you might end up with arthritis. If you're able to chill out and take a break, if you have a little bit of damage, or find a way to increase support by others, increase support through other structures like the ligaments, or ensuring that you have adequate hydration so that you have proper pressure inside of the joint capsules, then you run less of a risk of ending up with damaged cartilage. Another thing that seems to influence certain joints, usually the hips and the knees, is your height and your weight. So individuals that are very tall, for some, they believe it's their weight just because they're really tall. Sometimes they end up with more pressure on the joints, leading to joint wear and tear, and eventually osteoarthritis. Some of the most successful runners I know are very small. We just don't, and I'm very small. I just don't carry a whole lot of weight, and it doesn't seem to be affecting my joints too badly. I end up with bursitis much more often and tendonitis. Other injuries would be, for example, tear of the meniscus or a tear of one of the cruciate ligaments. We have the lateral and the medial. So let's say, for example, somebody gets tackled, a football player gets tackled from the back, and for some reason there's a blow to the back of the knee. That blow can cause a tear in the tibial medial ligament and potentially the anterior cruciate ligament, breaking up the entire capsule cavity. And that is really a very dramatic injury. It can damage the medial or the lateral meniscus as well, bursa. It's a real mess. And so once these ligaments are repaired, oftentimes you'll see an extreme difference in the range of motion between the injured and uninjured joint.